Hi, everybody. My name is Dr. Ravindar Mehta, and the topic given to me is airway stenting in malignant central airway obstruction. I've taken it from the picture of lung cancer to the larger picture of malignant CAO, and the focus is on techniques and complications with a case based approach. I first would like to thank Rajiv Goel for calling me to take this talk and hope that it adds to the bigger picture of an interesting meeting which has been organized on this extremely important topic. So today's focus is going to be by and large, we're going to talk of didactics literature, but we'll base it on cases and videos and leading to data. We'll start with some real world illustrative cases, talk of the core issues, go over what all else is there in data, and then summarize the whole talk in the 15 minutes we have. The case is an interesting prototype which epitomizes these principles. A 59-year-old with a renal cell CA after nephrectomy gets hemoptysis, has a CT scan showing a node going into the left main bronchus and narrowing it. Bronchoscopy is also showing a narrowed left main bronchus, which will show you with a big problem over there. What do we do? Dual problem of both airway obstruction and recanalization. Well, we started over here. You can see the check bronchoscopy going in under suitable sedation. Left main bronchus blocked. Clearly, the tumor is a cause of this bleed over here. And so, in this situation, something needs to be done. A therapeutic modality approach is planned. We go in there with a rigid bronchoscope. We have to both recanalize the airway as well as fix the hemoptysis. Over here, you'll see the operator using suitable tools, the rigid bronchoscope barrel. A balloon goes in there so as to figure out the distal airway. Keep in mind, no distal airway, no recanalization. A stent is put over here. Just to show you once more, this is a metal stent which has been deployed over there, and this stent has serves the dual purpose of both recanalizing as well as helping us to control the hemoptysis. So for those of you who have missed it, here is a distal airway wide open, very important for a bronchoscopist. Here is the stent, and that is the procedure. The patient did well after that, and at least his immediate problem as well as his issue of trying to get the airway back was solved. A second case to show you similar principles, a bronchial asthma gentleman, a case of bronchial asthma with a past history of malignancy comes with shortness of breath. Everybody calls it an asthma exacerbation, but no, the CT shows there is a mass going into the trachea, which is evident on these lung windows. It's a problem because initially treatment has gone on the side of asthma and he's not responding to asthma therapy. A quick bronchoscopy gets done. You can see there is major trouble out here. This is the trachea. So again, to show you all over again, this is the vocal cord. The operator walking down cautiously. There is extrinsic compression, vascular compression. The operator tries to slide past over there to try and see the distal airways. The distal airways are full of pus over here because of post-obstructive infection. So we have a major issue out here, but the distal airways are open. And we will come back to this point later when we review literature. So clearly something therapeutic needs to be done to make this gentleman come out of his distress. And a Y stent is put over there. You can see this is the limb, the left main limb of the Y going over here, which recanalize that area. This is the right main limb of the Y and the open right main bronchus. And here up is the tracheal limb of the Y, which you will see very clearly appreciated, the tracheal limb, which is totally giving us successful, comprehensive tracheobronchial airway opening. So this gentleman had immediate relief of his symptoms, did very well, and basically went in for multimodality therapy. A third case to show you some of these principles, CA thyroid with tracheal involvement. Initially had a rigid bronchoscopy similar to what we showed you. A stent was placed, but the patient just could not tolerate the stent. So the stent was removed. That was a metal stent. SEMS stands for self-expanding metal stent. Again gets hemoptysis, so you have no option to airway recanalization. Here goes in the operator over here. We went in with a rigid scope, bad airway compression. You don't need to be a pulmonologist for all this. And this has happened after metal stent removal. Here you can see cauterization happening with appropriate instruments over there, and then balloon dilatation to restore the airway. And then you can see this is a silicone stent. We showed you metal stents before, silicone stent because he could not tolerate the metal stent. A silicone stent is adjusted appropriately. The operator is opening it nicely over there. It does the job of recanalization. We are putting a tug over there to make sure it's a good fit, and that gives this person their airway back. What do these three cases show us? Where these are all stenting done for central airway obstruction in malignant disease. So now the main topic, technical details. What did we show you? We showed you that the stents can be either silicone or metal. So that is one decision point. In malignant disease, you can do either one of them, but the leaning is towards metal for multiple issues, predominantly cost and easier technique, and the technique part will get into why. In benign disease, on a small note, that's only reference, metal should be put only as a last option and only a completely covered metal stent and no less. Otherwise, silicone is put. The principles in any obstruction is you got to go beyond the obstruction. So this is the distance, at least zero point 0.5 to 1 centimeter above and beyond as much as possible. And ideally, more than 2 centimeters below the vocal cords so as to prevent irritation, which may be not always possible. Inner stenotic lesion we dilate, and then there are some things called hourglass stents which you don't have a country. You saw us trying to make sure the stent is a tight fit to prevent migration. Other technical issues, why do we prefer a metal stent? Because it can be done by flexible scopy, which is what most pulmonologists are comfortable with. Silicone requires a rigid scope, so that's why in malignant disease, by and large, most people prefer metal in addition to the cheaper cost. Other areas, technically, where there's distorted anatomy, the metal will find its way, so metal is preferred, especially with compression, which is a feature of malignancy. In a Y stent, rigid is preferable, but very technically, adruat and skilled operators like Dr. Goel will prefer a flexible. Otherwise, a lot of us will use a rigid scope. If you have to customize the right upper lobe, now we're getting into geography. You have to make a small hole that cannot be done with a metal because it's a single conduit, so silicone is better. In a fistula of a malignant nature, we prefer metal because it approximates better. Ultimately, with all these factors, local expertise, cost, stability, and anatomy will be the decision making for which stent. But let us see what data is there when we go through these theoretical principles. In this interesting paper which came out a while ago, they looked at what are the decision making points over here. They developed a prediction model. Favorable results are there with tracheal location, endobronchial disease, and extrinsic compression. And there's a reduced likelihood of success if there's a left main obstruction or mucosal infiltration. All these rules get broken in some of the cases we showed you, but data showed us these particular aspects. So by and large, this is a case in a novice and a beginning situation you would like to select. Another paper which talked of predictors of survival in malignant obstruction. Patients who benefit the most will be with purely endoluminal lesions in whom a technical success was achieved, like our cases. Those on whom cancer-specific treatment was initiated, that means you had stuff beyond the stent. You could give them chemotherapy, radiotherapy, immunotherapy, and so on. And distal airway patency on thoracic CT predicts the technical success. We extended that to bronchoscopic opening. We paused and showed you that where the distal airway opens is where you have success of a true nature, which is patient beneficial. Understand that is why between radiology, oncology, and technical pulmonology, it's multimodality all the way. And this message, I'm sure, comes to the length and breadth of this meeting. This is a recent paper in 2020 which puts forward all the principles I talked about, a good paper to read. And again, they talk of the silicone and metal paradigm, which we have discussed at length. Complications, the second part, complications are part of our lives. It could be, and this is a myriad discussion, but I'll make it brief in the time we have. Either it's insertion-related complications related to anesthesia, rigid bronch, flexible bronch, or technical issues. You haven't sized it correctly, obstructing segments, and so on and so forth. Later, it is not a panacea. Since the airway is a mobile area, you breathe all the time, and there is external environmental influences, granulation, obstruction with secretions, and a tip for that is don't overstent. It's not like cardiology that 4-5 stents are good. If you try to put Y stents, Y plus main stem stents, the airway will not allow secretion clearance, especially understanding these patients are weak, they have cancer, and they have infections. So do that, and nebulization helps in trying to clear the airways. Migration is a problem. Stents are like mechanical devices. They're subject to technical issues. And if you have to take these out occasionally, it can be a problem to take out metal stents because they tend to marry the trachea with a lot of sticking over there. Complications, more papers out there in a registry which came out recently in chest. By and large, endoluminal obstruction, as we said earlier, and stent placement favored technical success, like our cases. and they also did not like the left main lesions, albeit we showed you a good one in our lecture. Additional predictors of failure are patients who are sick, renal failure, primary lung cancer, very interestingly, and T fistula. Nevertheless, this is one observational series. There are anecdotal and other observations which may or may not totally agree with this. Primary result complication rate 4%, though in our mind, and Dr. Goel may agree, and other people may also concur, it's much more than that. What is our other papers out there? Another person, single center experience, said that median survival was 15 weeks, 2% risk of complications, as we talked about, and most of them don't like renal cell carcinoma, though we've shown you one case of RCC, which was dealt with in the first case we described. Indian imprint, a lot of us got in together, including Dr. Goel over here, including our group and the AIMS and PGI people, and Coimbatore, where we showed that you could put in Weistent successfully in India, and one of the largest series of Weistents in literature with a decent outcome, most of them being CA esophagus as the indication. And a similar imprint again with both Dr. Goel's group and a lot of us, including PGIMs in Hyderabad and Coimbatore, who have also showed the same thing can be done in silicone wise states. What about migration? We had a particular paper where we showed that you can actually do a percutaneous stitch to prevent migration and mitigate the complications, especially in these oncology patients where we don't want these patients to go through repeat procedures. It's a simple stitch with a subcutaneous closure, so it does not leave us a major outside button or a disfigurement. So it has been an innovation which we have put out there in worldwide literature. New things out there, well, customization. Why not customize these stents? And I don't have time for details, but 3D printing is coming in stentology so as to make things better over there. And you can see these pretty pictures which are trying to make sure these weird shaped lesions with compression can be somehow compensated by preparing 3D printed good stents. Another concept borrowed from other areas like cardiology and maybe GI, why not have a stent which disappears? So if in a malignancy you put the stent, all those complications of granulation infection, foreign body can be mitigated. And the biodegradable stents have come out, not in India, we have to get them from abroad, which are now also being used, a space we need to watch out, which is very interesting and very provocative. So to summarize the whole talk in the talk time we had, airway stenting, good for large airway obstruction, trachea and main bronchi. We have silicone and metal in India. Hybrids are not common over here. We prefer metal in malignancy by and large for multiple reasons. And the technique of flexible and rigid has been mentioned for the type of stent. Complications we dwelt on in length can be challenging and life-threatening. So you have to be very cautious in your decision making and in your procedure and follow-up. This is a paradigm shift in the treatment of malignancy patients. Funnily, people earlier used to not do cancer patients, but here more the symptoms, more sick they are, more the benefit. It is a paradigm of contrast over there, which we have to reconcile and adopt in our practice. Metal, it's not too difficult to deal with complications as long as the indications are correct. Please remember, plan well for both short-term placement and long-term management of these patients. Also remember that sometimes when you open, you may not need a stent for everybody. If the patient outlives the planned stent duration, you need an exit plan, either manage the complications or get the stent out, something which you have to think on as you develop your stentology intellectual quotient. So to summarize the whole talk, airway stenting is usually a last option, which is done in the way we mentioned. Surgical approaches are paramount, but in malignancy, often we are the option of last resort, and that is why we got to know this very well. Technique involves decision making. Also, A's biggest point: can I open the airway? 2, is it a good candidate? 3, after opening, do I need a stent? And more importantly, what is my exit strategy and management strategy and follow-up strategy? As we keep on saying, stenting is just the beginning of the story and has to be put in the context of first a comprehensive interventional pulmonary strategy and secondly a comprehensive multimodality strategy to do good to your patients, because ultimately we are not trigger happy people. We like to give stents only for people where it's absolutely required. With this particular message, we end the talk. Thank you very much for calling us again. And